Today we are discussing abnormal uterine bleeding as part of IAM2 module. We will be discussing a case scenario and then try and see how our knowledge about diagnosis and treatment can be incorporated into analyze and come to a management plan. So our objectives are to recall our knowledge about abdominal uterine bleeding. For that, I would recommend that you follow IAM1 lecture I have delivered earlier to your junior group, and I'll put up the lecture slides as well as the video on your module as well, so that you can access it and refresh your knowledge about diagnosis and classification of abdominal uterine bleeding. Then we will see how we can analyze a case scenario and how we can evaluate it to come to a possible differential diagnosis and identify a list of problems, and then apply the knowledge to develop a plan of management and treatment. If we briefly recall, most of the menstrual cycles, though we consider them as 28 days in length, it can vary between 24 to 32 days. The regular cycles are not always necessary or seen. At the beginning of the menstrual periods, or close to menarche, and towards the end of the menstrual cycles towards the menopause, the cycle length varies. So generally between 20 to 40 years, women will have regular cycles. Before that or after that, the cycles can become irregular and can become a nuisance and sometimes needs treatment. It's not always pathological. The mean blood loss per cycle again varies between woman to woman, and from about 37 to 43 millimeters. In general, on average, the total fluid blood loss is around 80 ml. Menstrual dysfunction or disruption can be of the timing or of the flow, and is one of the commonest reasons why women attend gynecology clinic. If you have attended a gynecology clinic, you would see that it is so common. And it is better, as I mentioned earlier, to go through the IAM1 module, because we need to know a little bit more about menstrual hygiene and how it is controlled as doctors to effectively treat our patients. In the normal menstrual cycle, at the beginning of the cycle, which is the first day of the cycle, the hormonal levels which maintain the endometrium, estrogen and progesterone are low, and FSH coming from the anterior pituitary will start recruiting a new follicle from the ovarian reserve, and then they will in turn secrete estrogens gradually from the developing follicle. And those estrogens will initially suppress FSH and LH, but then gradually, after a certain limit, will positively feedback and increase rapidly the amount of estrogens, and that will increase FSH, increase the amount of FSH, and that will trigger off a ovulation. FSH and LH together will trigger off ovulation, and that will cause egg to release, and then the remaining granulosa cells become corpus luteum and produce progesterone for the second half of the cycle. If there's no pregnancy, the corpus luteum will be there for about 14 days, and after that it will start going atrophic, and there's a lack of support from the dwindling corpus luteum will trigger off a endometrial breakdown and blood loss as menstruation. That is, in a nutshell, what happens during menstrual cycle. There are two types of abnormal uterine bleedings. We can have women who are having regular ovulation. We can have women who are not having ovulation. Generally, ovulatory cycles are predictable because they have regular cycle. Most of the time it is due to a problem with the imbalance of prostaglandins and fibrinolysis at the endometrial level. So most of the time it's related to endometrial. Whereas anovulatory abdominal uterine bleeding is due to lack of luteal support, most of the time from the corpus luteum. So the corpus luteum is not producing enough progesterones to support the endometrium, and as a result the endometrium start breaking down and women will start menstruating. So this simple classification is not always enough. So in 2015, the FIGO, the International Organization of Gynecologists, came up with a new classification which is called palm coin classification, based on the causes for this abnormal uterine bleeding, and it is comprehensively covers all the possible etiologies, and is the one which we are using now. So they have covered it in detail in IAM2 module lecture, so you are again referred to that lecture. As a general rule, women in reproductive age are always pregnant unless proven otherwise. So anybody with abnormal uterine bleeding can be bleeding because of a complication of pregnancy. So keep that in the back of your mind always. So if the woman can get pregnant, or is possibly in that age range, always exclude pregnancy before treating them for any other cause for abnormal uterine bleeding, because pregnancy and its complications can easily mimic all the other pathologies like adenomyosis, myomectomies, hyperplasias, coagulopathies. It's very easy for pregnancy to mimic any of the symptoms and signs of these causes. So these are the two differential diagnoses based on anovulatory and ovulatory classification, simply whether they are ovulating or not. People don't ovulate during immediate post-menarcheal period, adolescence. When you have uncontrolled diabetes, we have eating disorders, hypothyroidism, hyperprolactinemias, on treatment like anticonvulsants or antipsychotics, or when you come to the end of your reproductive life in the perimenopause. And again, commonest reason for anovulation is in reproductive age is polycystic ovarian syndrome. When you ovulate, again, hypothyroidism can still be there. On top of that, even hyperthyroidism can still ovulate and have irregular bleeding. So anybody who is having irregular bleeding and showing any clinical signs of hyper, try to do a thyroid function test. But that doesn't mean that everybody who comes with irregular bleeding needs thyroid functions. No, it's unnecessary expenditure. People with Down syndrome, people with hemophilia, or leukemias, or having various factor deficiencies, factor 8, 9, 5, and platelet disorders, von Willebrand disease, Glanzmann thrombocythemias, liver diseases, or women with fibroids or polyps in the endometrial cavity, all of them will have still ovulating but having abnormal bleeding. This brings us to the case scenario. We have a 28-year-old woman referred to a gynecology clinic due to heavy regular periods. Keep in mind it's heavy but it is regular. She is married but does not want to have a pregnancy immediately. She at the moment uses a barrier contraception in the form of condoms, but on examination she looks pale and tells that she passes clots with the menses. She has had a pap smear a few months ago, almost normal. And clinical exams, examination and ultrasound abdominal pelvis is normal. So when you are faced with somebody like this, you need to analyze the history or analyze the question if it is an exam question, and try to classify what is given and what is implied in the question. Now, this patient has regular cycles. So if somebody is having regular cycles, most of the time, 95% of the time, they have ovulation. So it's the type of ovulatory or abnormal uterine bleeding. At the same time, though she is not pregnant, she wants to preserve her fertility. She has pallow, passes clots, probably some symptoms of anemia is there. So we need to verify it further. And then if somebody is having heavy bleeding, it is not only due to abnormalities, the endometrium or endometrial menstrual cycle, maybe other diseases like coagulation disorders or the problem with formation of blood like thalassemias. So we need to go into detail about her blood investigations and see hematologically. And we need to see coagulation disorders, which cause heavy bleeding, and possibly, if everything turns out to be normal, without any polyps, fibroids, so no anatomical problem with the blood cavity, it may be due to ovulatory abnormal uterine bleeding, possibly due to the endometrial causes, either imbalance of prostaglandins and fibrinolytic activity, and it is one of the commonest reasons for abnormal bleeding. So we will stop there and then go a little bit into detail about how to assess somebody with heavy bleeding. So what are the other information? That is where our information gathering exercises in the form of history, examination and investigations come in. So whenever a patient presents, that whatever she or he tells is not adequate, so we will dig into their story. So we need to get a targeted history. We need to identify what is the nature, what are the symptoms, any suggestions of a structural abnormality like any abdominal discomfort, a mass being felt, or a lump coming out of the vagina, or whether there has been a note of a fibroid or any other mass in the pelvis in any of the previous healthcare encounters or ultrasound scans, and how this bleeding affects their quality of life, other treatments they have taken. All this needs to be taken into account. Then we need to get information about the cycle duration, frequency of blood loss, and the amount of blood loss in the form of number of sanitary pads and things. If the bleeding had been heavy for a longer duration, it is better for you to give them a menstrual diary to identify amount and timing. Sometimes it is helpful when your examination doesn't reveal that she is really having a severe anemia and probably not having much of her bleeding. Ask them to maintain a diary so that you can have a better objective idea of the blood loss. Signs of flooding, clots generally indicates significant loss, and maybe tiredness, breathlessness at rest, maybe they are in severely anemic patients. If somebody has intermenstrual bleeding or postcoital bleeding, it may be a problem of anatomical reasons, a polyp or CEA cervix may be there, so we need to exclude that with the pap smear history as well as speculum and colposcopy if necessary. Then pressure symptoms of a large fibroid again will indicate abnormality. History of coagulation, bleeding into joints, easy bruising, gum bleeding, or any surgery related bleeding, or the bleeding after delivery, and will give a clue towards coagulation disorders. And generally these patients will have heavy bleeding from menarche onwards, or they may have had blood transfusions, multiple hospital admissions since menarche. So that is a good reason to suspect a coagulation disorder if the woman is slightly older. But when you are faced with a very young girl, if they repeatedly come, or if the bleeding is heavy, always think about a possibility of coagulation disorder, especially one-way different disease. They say it is quite common among adolescents with repeated heavy menstrual bleeding, and most of the time being ignored by health professionals for several years before diagnosing. So you have to be open-eyed with coagulation disorders. Don't ignore. And generally, if you have bruising greater than 5 centimeters, epistaxis once a month, or family history of bleeding disorders, those are all clues for coagulation disorders. Then we come to examination. It has to be a general examination to see signs of anemia, see any signs of coagulopathy or thyroid disorders. Abdominal examination should be a pelvic bimanual examination, speculum examination, and you need to see the vulva, vagina and the cervix, check for polyps, any discharges from uterine cavity with suggest infection in the endometrium or endometritis. And as I mentioned earlier, a bimanual is essential for pelvic mass. Then it brings us to investigations. We have laboratory tests like full blood count. Everybody should have that. And then if you have your history suggests a coagulation disorder, do investigations or referral for coagulation profile testing. Everybody doesn't need ferritins, LH, FSH, testosterone testing. Even thyroid functions should be done only when signs and symptoms of the disease are present. If the woman is older, generally above 40-45 years, or those who have high risk of endometrial cancers like polycystic ovarian patients with long durations of anovulation, you need to think about doing endometrial biopsy. Just a bit of caution, if your pupil biopsy is not always the best form of sampling if you suspect focal lesion. If you have a possibility of focal lesion, the best clue is to see the ultrasound scan, where you can see a small area of echo dense area, that is the area possibility of polyp is there. So if polyp is possible, pupil will not pick it. In those cases, always go for hysterectomy and do a biopsy, targeted biopsy. In generalized enlargement or global thickening of the endometrium like this, pupil is adequate. So you have to be careful and choose your sampling technique following your assessment of the endometrium with the transvaginal scan. But if you don't have any other way of sampling, even pupil is okay. Imaging is almost essential. Ideally it's a transvaginal, but if you have abdominal palpable mass, abdominal examination has to be carried out. It will tell us about uterine abnormalities as well as ovarian pathologies, which might secrete hormones and cause secondary menstrual disorders like granulosa cell tumors or theca cell tumors. And most of the time you can easily identify polyps and fibroids or thick endometrium due to a possible malignancy, especially closer towards the menopause. And there are various cutoff points you will learn in your malignancy lectures, and they all will help in diagnosis. So this is a summary of all the possible generally done investigations and their indications. And then we come to treatments. Treatment decisions are generally done jointly with the patient, and we need to take into account her wishes. So if somebody wants to conceive and keep her uterus, we are not going to offer them endometrial ablation or hysterectomy. And most of the time, medical treatment is preferred in a younger age group, and surgical treatments are preferred in older, family completed women. And in our case, she's a 28 years old woman, not yet pregnant, wants to keep her fertility, and since she wants to delay it further, we may have to couple that with the contraception. So whatever choice we are making should be effective for abnormal uterine bleeding, should preserve her long-term fertility without impacting on it, and until that point should provide some sort of a contraception rather than needing another contraceptive method, which are generally again prone to cause irregular bleeding. Okay, so that narrows down our treatment possibility. That is how we incorporate patients' views into our management plans. So leave it and we'll go back again to theory. Now, treatment generally comprises of pharmacological and non-pharmacological or surgical treatments. Pharmacological treatments are again subdivided into hormonal and non-hormonal. Whatever the treatments, generally hormonal treatments are more effective, but we consider them in a particular order. Usually pharmacological treatments are effective when there are no structural or histological abnormalities like a malignancy or hyperplasia is there. Even when they have fibroids, if it is less than 3 centimeters, and generally if they do not disturb the cavity, they have a place in treatment. But when you have a large fibroid, there's no point going and treating them with hormones repeatedly, and whatever your medical treatment, usually it has to be limited for about 3 months. If it is not successful, think about another option. They are considered in this particular order. Best form of hormonal treatment is levonorgestrel releasing intrauterine system or Mirena. And if the patient needs treatment for more than 1 year, because it's expensive instrument, you need to use it for people who are on the long run treatment, and it is the best because it goes into the cavity and release the progesterone into the cavity locally and will keep the endometrium suppressed. Tranexamic and NSAIDs the next option, and then oral contraceptive pills. Those are the second level. Progesterone, which is commonly prescribed, or progesterone for about 21 days in cycle, or injectable long-acting progesterones like Depo-Provera or Depo-Medroxyprogesterone are the third level because they are not that effective. So if you want to get the best treatment, levonorgestrel IUCD is the one for women who need treatment for long run. All other patients you can try NSAIDs and tranexamic acids or contraceptive pills. Other treatment options like GnRH analogs, injections or nasal inhalation can be given, but they are expensive, so that has to be taken into account, and they are not freely available in the government healthcare sector. We have been using drugs like danazol, ethamsilate, gestrinone, but they are no longer used because of their unacceptable side effects: weight gain, acne, virilization, voice changes, mood changes. All these things are fairly unacceptable. Because of that, we do not use them regularly. Generally, non-hormonal treatments are useful in patients who do not like hormones or planning to get pregnant, or until you complete your investigation like hysterectomies and ultrasound scans and biopsies and coagulation profiles, you use these methods. You need to know a little bit about pharmacology of these drugs. I'm not going into detail, but please refer your pharmacology notes and or books and read about them. Tranexamic acid is an antifibrillolytic. Generally, they reduce the blood loss around 60%. It is by inhibiting the fibrinolysis. In menstruation, before the menstrual flow begins, the blood clots in the uterine cavity. Then the fibrinolytics in the endometrial cavity breaks down that blood clot into small clots, and these will come out as altered blood with menstruation. That is why menstrual blood is darker. When fibrinolysis is excessive, there will not be any formation of clots, which will generally block the blood vessels leaking lot of blood, and they will in return will pass large amount of blood. So tranexamic acid blocks this fibrinolysis, so the fibrin clots are intact and will be kept longer than normal, and that will reduce the amount of blood loss from the open blood vessels in the endometrial base, and it will reduce the amount of bleeding. That is a theoretical foundation for usage. No major side effects. You will have a bit of indigestion, diarrhea, headaches, and there were concerns about thrombosis when you are on higher doses, but the doses which we are using currently, 500 milligram to 1 gram, 3 times a day maximum, it's not seen commonly. And evidence is that it is effective rate reduction of measurements of heavy loss compared to NSAIDs and other progestogens. NSAIDs are the second level compared to tranexamic, but still is useful when you have heavy menstrual loss plus pelvic pain or dysmenorrhea. Again, it will reduce not as much as 60% with tranexamic acid, but about 25% loss is noted with mefenamic acid. You can use it with sometimes use it with antacid, because gastrointestinal has side effects like diarrhea, indigestion, asthma getting worse, or triggering peptic ulcers is there. But NSAIDs are always preferred when you have dysmenorrhea. And since prostaglandins are essential in ovulation, if you use NSAID in a woman who is planning a pregnancy, there may be effect on the fertility. So it's not the best drug if you plan to be pregnant and only want to reduce the amount of blood loss. Then go for tranexamic acid alone and don't combine with NSAIDs, because it predisposes to non-rupture of the follicle, which is called LUF, luteinized unruptured follicles remaining in the ovary, and they can be a problem in achieving a pregnancy. Cochrane review says NSAIDs reduce heavy bleeding compared to placebo, but less effective than tranexamic acid, danazol, or LNGIUS. So you can see that it is come down in the lower levels of effectiveness compared to others. And if symptoms do not improve within 3 cycles, stop them. There's no point continuing with them. So maximum is for 3 cycles. Don't go on prescribing them for years. Now we come to hormonal treatments. We have combined pill, and it is found to reduce the blood loss around 43%. Its side effects are numerous, but they are all mild most of the time. Head mood changes, nausea, breast engorgement, and in women who are having predisposition, thromboembolism is there. Smokers, obese, older women, you have to be a bit careful. But up to about 40 years, OCPs, but various levels of strength, 30-35 micrograms of ethinyl estradiol to 20 micrograms. You have a wide range of drugs. They are helpful. And when you want to treat additional symptoms like hirsutism, there are preparations which have progestogenic action with less hirsutism, like Progesterone or Jasmine. They have anti-androgenic action as well. So there are various ways of treating other additional associated symptoms with OCP. So it's a good choice in certain patients. In the other hormonal treatment is long-term or 3-weekly progesterone. So we usually give it as progesterone or dydrogesterone. (10 milligrams BD in that case for about 21 days, from the 5th day to 21st, 6 days of treatment to heavy bleeding. But being progesterones, they cause weight gain, bloating, breast tenderness, headaches, acne, depression and everything. So generally, it's not a good choice for longer term. It is always a short-term measure for holding menorrhagia until you go for definitive treatment. Same effects with long-acting injectable progestogens like Depo-Provera, lipomethoxyprogesterone acetate. And if the woman is needing a long-acting contraception, you might use it. But keep in mind that it can cause irregular bleeding, weight gain, amenorrhea, and effect on the bone density, especially if the woman is close towards menopause. Long-term osteopenia is a major thing you need to consider because its effect on their long-term bone health. So not everybody is a good candidate for long-acting progestogens. Levonorgestrel releasing intrauterine system, as I mentioned earlier, is the best choice. And people who want to treat their heavy bleeding as well as contraception, probably the best. It releases progesterone at 20 micrograms per day and locally acting, thinning the endometrial and causes the endometrial to atrophy. So in a way, it will prevent endometrial hyperplasia and malignancy coming up. So even when a woman has polycystic ovarian syndrome and wants to control her cycles, this is better because PCOS patients in the long run, due to their hypersecretion of estrogen and prolonged anovulation, can be predisposed towards endometrial hyperplasia and malignancy. So this is a treatment for them. Side effects are there. All progestogenic side effects: breast tenderness, headaches, acne, and at the time of insertion, if you are not careful, a perforation. Initially, after 1 year, it reduces blood loss in 95% of the time. But you will not see much benefit in the first 6 months. Patients need to be told that in the first 5 to 6 months they might get spotting and bleeding, and that is not a reason to discontinue. So you might add tranexamic acid and OCP for the interim period to control the bleeding. GnRH agonists are good if the woman is having additional symptoms like pelvic pain, endometriosis, or fibroids which are going for surgery. Interim period you might use it. Generally we don't use it for longer durations, but they achieve their effect by ovarian suppression and causing amenorrhea by affecting on the hypothalamus pituitary ovarian axis. Then we don't use it for more than 6 months because long-term absence of estrogen causes effects on the bone health. And if you another perimenopausal symptoms, so we might add back some hormone estrogen in the form of estrogens or estrogen-like action, like drugs like Tibolone can be used to add back some of the lost estrogens. Danazol, it's an effective treatment, but we don't use it regularly because of very bad side effect profile. Hirsutism, voice changes, and long-term effect on the liver are all concerns. A newer drug is SMAYA or ulipristal acetate. It's a progesterone receptor modulator. We know that estrogen receptor modulators are clomiphene, tamoxifen, raloxifene and raloxifene. This is a similar type drug on acting on the progesterone receptors. So if a woman has fibroids, this is a good choice. Moderate to severe symptoms in adult women in reproductive age. This is good because it directly acts on 3 target tissues: the fibroids, endometrium and the pituitary. All are suppressed. You need to give it daily 5 milligrams for 3 months maximum, right? And you can repeat 3-month course several times. You have to have generally after one course about 2 months of treatment free period. This is to allow the endometrium to come back to normal, because long-term suppression with this SMAYA is probably not a good idea. So you can start the second cycle on the first day of the first week of the second menstrual cycle after stopping for 2 months. And generally not recommended to exceed more than 3 months. We have studied up to about 18 months duration. Various studies were going on to evaluate its course. It shrinks the fibroid, so even prior to surgery it can be used to reduce the size of a very large fibroid, and especially if it is encroaching onto the endometrial cavity, this is a good option. It is generally not recommended when you are breastfeeding or having unknown genital bleeding, usually with uterine or cervical, ovarian or breast cancers. It's not a good idea. People have got pregnant while on SMAYA. And recently there was concern about liver damage with long-term treatment. So actually there is a warning against SMAYA's long-term use at the moment. So this table, I'm not going into describe everything. I have gone through most of the things in the earlier, but you can refer this up in the lecture notes which are there on the scene. It's a summary table giving the mode of action and effects of menstruation and whether they have contraceptive benefit or not and other side effects. It's a good revision aid for you. That finishes the pharmacological treatment. Now we come to the surgical treatment. Surgical treatment used to be the mainstay prior to 1990s. Around 60% of women who had heavy bleeding went in to have a hysterectomy. It was the commonest surgical procedure in late reproductive life in women. Then we had reduction of hysterectomy rates because of levonorgestrel intrauterine system as well as other surgical methods like endometrial ablation. So there's a change from hysterectomy towards uterine preserving treatments with surgery. Common surgical treatment is polypectomy. If you have a polyp, you can do polypectomy under hysteroscopy resection or with the DNC or polypectomy forceps. You can do. It can be done outpatient using various proprietary methods like Versa Point or MyoSure. We don't have them. We use normal hysteroscope or sometimes even diagnostic hysteroscopy followed by a polypectomy or curettage. Then we come to endometrial ablation. Endometrial ablation, the principle is destruction of the endometrium. We are distracting endometrium targeted. This is done in women who do not have a plan for pregnancy and but want to keep the uterus and have a poor quality of life with heavy bleeding. Generally, it's not indicated in uteruses larger than 10 weeks, comparable to 10 weeks pregnancy. Fibroids, if they are less than 3 centimeters, you can still go for endometrial ablation, but anything more, you should not. The first generation endometrial ablation techniques were using hysteroscopic trancervical resection and with the laparoscopy loop or roller ball. And even with submucous fibroids, this could be used. But there was a steep learning curve, perforation, deaths have happened. So they are not the best treatments. So people look for easier techniques. Then we have multiple varieties of treatments which are there. One is Novasure, the other one is thermal balloon ablation or hydrothermal ablation. So these are impedance linked or electrically activated mesh lighting which goes into the cavity lining and touches the cavity and burn the cavity by heating it. Thermal balloon ablation, you put a small balloon which will take up the space in the uterine cavity and then put water into the cavity at around 85 degrees centigrade. Hydrothermal ablation, you directly put, you seal off the endometrial cavity here and then put water, heated water directly and burn the endometrium. So all these conditions can be done as day case. But these are all indicated for smooth small endometrial cavity, not for women who have very enlarged endometrial cavities, because they can fail and they are not optimal. Since it is just a burning of the endometrium, there is a possibility of some pockets of endometrium remaining. They may not cause bleeding, but still they can become pregnant. So you need to advise the woman to use contraception. So it doesn't mean that she is completely free of endometrium. And since possibility of malignancy is there always before surgery, ablation procedure, you need to take endometrial biopsy. Hysteroscopy has to be done before as well as after, especially done after to avoid detect any endometrial perforation. Cramp pains, watery discharge is common, and long-term complications are perforation, endometritis, hematometrons, fluid overload from the distension medium, and if the perforation occurs, burning of the bowel and other visceral organs, bowel and bladder. So these are major problems, but not common. So these things are done in other countries as outpatient procedures. Roughly 1/3 will become amyleric, 1/3 will have marked loss of blood loss, and about 20% will not have any effect on their bleeding. Long-term trials shows that the women are generally satisfied initially, but about 15% will need another procedure. So they will repeatedly come, especially if you do the ablation early in life, your chance of repeated procedure is high. So long-term cost saving is not that good because you need multiple procedures. So compared to hysterectomy, initially it is cheaper if you need only one procedure, but if you need repeated procedures, probably difference is not that much. So the cost difference between hysterectomy and ablation is not that great, but you have the option of keeping your uterus until you die. Myomectomy is indicated for people with fibroids, intramural or subserosal, can be done hysteroscopically, abdominally, laparoscopically, and you need to think about difficulty of achieving hemostasis and then damage to the endometrial cavity and need for major incisions in the abdomen and long-term problems with them. Other major side effects of myomectomy are infection and its effects on tubal fertility, because if the tubes are trapped in adhesions, again that is a cause for subfertility. Uterine artery embolization is another problem we have. Treatment procedure for problem of heavy menstrual bleeding, and we usually use it under radio fluoroscopic angiography guidance. We inject particles into the blood vessels supplying the fibroids or the uterus. And generally this is recommended only for women who have completed their family and long-term uterine artery embolization does not have much effect on the rest of the uterus apart from the fibroids. So it's useful, but still it is considered the experimental procedure. Long-term fertility is uncertain, so it is not recommended for people who are planning a pregnancy in future. You can get ischemic pain, you need this pain relief for that, and long-term sepsis risk is there. Some fibroids, especially if they are submucous, can get expelled through the cervix, so they can get crampy pains and they may pass the large fibroid out of the cervix. But it is a good choice for people who have a very well circumscribed intramural or submucous fibroid. Sub-zero cell ones might cause additional problems if the bowel is adherent to the fibroids, because it can lead to bowel necrosis and peritonitis. And risk of premature ovarian failure with uterine artery embolization. Theoretically it is there. There may be cross supply to the ovary from some of the uterine vessels along the round ligament of the ovary, but theoretical risk is not shown in practical sense. That brings us to our last choice, which is hysterectomy. You can do it vaginally if there is uterus with a descent, especially in older female, it is possible. Problems of surgery are less with vaginal approach, less post-op pain, early mobilization, early discharge home, and doesn't disturb the abdominal pelvic viscera. Whereas abdominal surgery is reserved for large uteruses with complicated pelvic histories, or when it is technically not possible to do vaginal hysterectomy with narrow subpubic arch. Or if there's no descent, you can do ascending vaginal hysterectomy, but if it is difficult with a large uterus, we will go for abdominal. So it is still the preferred choice for complicated procedures. And if there's a possibility of any other additional things like adhesions or malignancy, endometriosis, always abdominal procedure is better. If you do not remove the cervix in case of subtotal hysterectomies, residual bleeding is possible. You need to tell that to patients. In young patients, we don't usually remove the ovaries, but we will remove the tubes if they don't, to prevent their chances of ovarian cancer originating from the fallopian tubes. So we will remove the tube but leave the ovaries. But if you leave the cervix, always tell the woman that she needs regular pap smears to avoid the cervical cancer. And women should be counseled that 1 in 72 lifelong risk of ovarian cancer if you leave the ovary at hysterectomy. So it's not a small risk, but you need 72 women to sacrifice ovaries to prevent one ovarian cancer happening. Laparoscopic hysterectomies are increasingly performed. You can do total hysterectomy, subtotal hysterectomy, laparoscopic assisted vaginal hysterectomies, less post-op pain, less analgesia, early discharge, and problems. All these advantages are there, but if you have PID or endometriosis or previous cesarean sections and multiple adhesions, then laparoscopic approach may be difficult technically, and it needs people adequately trained and exposed to these procedures. Complications of all surgical procedures are higher with obese people, people with pelvic pathologies like endometriosis, PID or large multiple fibroids, people who have had multiple previous bowel or pelvic surgeries, or people with pre-existing medical conditions, diabetes, ischemic heart disease, hypertension. They have serious risk is following abdominal hysterectomy is 4 women in every 100. That means 1 in 25 will have some sort of a serious complication. It's not light. They include damage to the bladder, damage to bowel, hemorrhage, return to theatre because of wound divisions or bleeding from blood vessels, pelvic abscess infection, thrombosis, death. Within 6 weeks, 32 women out of every 100,000. So if you do 100,000 hysterectomies, 32 might die from some related cause to surgery, following surgery within the first 6 weeks. Wound infections, pain, delayed healing, keloid, tingling sensation, numbness around the scar, increased frequency of urine infections, premature ovarian failure, those are all commonly seen. They are common risks associated with hysterectomy. So you can see that hysterectomy is not a very simple choice, though we take it very lightly. Then we have newer technique which is called magnetic resonance imaging guided focus ultrasound. You locate the fibroid with the MRI, patient is kept on MRI machine, and then you focus ultrasound beam through a window of water, and then keep the patient still for about 3 hours and focus ultrasound beam to warm that fibroid and damage it. You need to raise the focus the ultrasound beam to increase the temperature locally in the fibroid. It's like thermal ablation, but not burning other tissues. Since it is focused, only the focal point will get heated. So if the woman moves, your chance of damaging or burning another area is high. So the risk is increase if the bowel adhesions are there. So it's limited only to people who have plain and simple large fibroids which can be easily targeted with the MRI, not for people with multiple fibroids. And it can cause bleed, bit of cramping, nausea, skin burns, bowel injuries have been noted because of the movement of the patient. But you can go back to work within 1 to 2 days from the treatment procedure. It is effective. Even successful pregnancies have been noted. And increasingly it is becoming available. In India it is available, but we don't have it in Sri Lanka at the moment. And sometimes you might need it in several procedures. So you can burn part of the fibroid now, and then after about 2 weeks you schedule another session. So you can do it in sessions. So that way you can limit your risk of damage. So this again, like the pharmacological treatment, is a summary table which you can use for revision. And we have few more slides. One is acute heavy menstrual bleeding. So you might be in the OPD or in the ward. Suddenly a patient will be wheeled into ward saying that they are having heavy bleeding. You need to first suspect that whether they are having coagulopathy or fibroids, usually a prolapse fibroid, or uterine arteriovenous malformations, or if they are on anticoagulations like warfarin or newer anticoagulants, they can bleed heavily. So it's generally not common for menstrual bleed to be very heavy. So suspect other causes. AVMs need to suspect. Initial management is ABC approach. Get the hemodynamic stability, get the cannulas, get the blood, and then try to stop the bleeding. If not, you need to take the patient to the theatre and do an emergency curettage sometimes. And generally, even a balloon tamponade might work in women with slightly large uteruses. So this summarizes our management protocol for heavy menstrual bleeding. When the woman presents, take the history, do the blood count, see whether there are structural or histological abnormality or not. If you do not have any structural histological abnormality suspected, you can treat them with pharmacogenic straight away. If you suspect structural abnormality, do a physical examination by manual palpation, speculum, and look for polyps or fibroids. Even if the fibroid is there, if it is less than 3 centimeters, you can do a ultrasound and see. Then again we go for pharmacological treatment. If endometrium is thick, intermenstrual bleeding is there, woman is over 45 years, or is on follow-up after ineffective treatment given earlier, then go for endometrial biopsy before going further treatment. And if you have a palpable mass, abdominal, pelvic, again think about surgical options. Then you go for imaging, confirm with ultrasound, MRI, CT scan. Then discuss with the woman about the long-term treatment option. People who have gone for pharmacological treatment, if they fail, again come back to this after ultrasound. If the impact on the life is more, but they do not want pregnancy but want to keep the uterus, and even if the fibroids are there, if they are less than 3 centimeters, endometrial ablation is the preferred. We don't have it here, but that is the best treatment in that subgroup of women. Then people who have had other treatments, failed, want to get rid of periods, and who's fully informed about all the risks and problems with hysterectomy, do not want the uterus or the fertility, go for hysterectomy, but keep the ovaries. People with large fibroids but want to keep the fertility and uterus, go for myomectomy. Fibroids larger than 3 centimeters but do not want to use the uterus, lose the uterus, think about uterine artery embolization. So those are the treatment options you have. So now we come back to our patient. Since the patient wants to keep the fertility, he is having regular period with heavy bleeding, we thought that it is due to a problem with the endometrium. And she wants to keep the fertility and delay the pregnancy, so she needs contraception. So we thought our choice of treatment as oral contraceptive. That is probably the best choice she can have. But if she wants longer term contraception, then you might consider LNG or US as well. But in our setting, this would be the best patient. Thank you. If you have any questions, please raise them in the comments.